On this episode, we talk about being accessible to clients, advanced ACL rehab, and more importantly, we answer the question, do we ever get stumped? The Ask Mike Reinold Show. Helping people feel better, move better, and perform better. Welcome back, everybody, to the show. Today we've got some great questions that the Gabeinator over here is going to share with us, right?
Right.
He's excited.
Yeah,
welcome back. So I guess this is our fourth episode, and you can see we're trying to kind of put the pieces together here. We're trying to, figure out a little bit of the formatting with, the video and the audio, but we're getting there. So bear with us. I think we're getting better, but, looking for feedback, and hopefully you guys are enjoying it. But let's start the show. Let's go questions, right? Gabe, what do we got today?
First question's from Andrew from Boston, Massachusetts.
Who's Andrew who?
Millet.
Andrew Millet. What's up, Andrew? I've known Andrew for a while now. Good young therapist here in the Boston area. I guess he's not super young. Sorry, I didn't mean to say that. But good, up and coming therapist in the area. So I've seen him at a bunch of courses. So thanks, Andrew. Thanks for submitting a question.
So Andrew asks, I know you have a family, and I know you've mentioned webinars before about being accessible to clients when you're out of the office. I was wondering, how do you keep a work-family balance so that you can be accessible to your clients, but also to your family?
All right, so question about really number one, I guess, being accessible to your clients, and then maybe Len, you can talk about what we do here at Champion. But
yeah, we treat our life here. We try to get our clients and let them know that whenever they need us, we're available, and it is difficult. I got to keep my wife busy at home, and so I can sneak her. No, I'm kidding. Mike was like, "What are we going?
Like, where are you going here?"
No, it is definitely tricky. You get a text message on Saturday that, "Hey, my ankle's sore. What should I do?" I eventually get back to it. I try not to go back and forth with text messages or emails, but there's definitely a challenge in trying to get information to the client as quickly as possible without killing the family life. My wife is, we're due to have a child soon, and that's going to change my life. And Mike's got children, so he lives it even more so than I do, and my life's going to change. So I don't know if I've added anything. It's a challenge, but it's doable.
Well, I guess the first thing I would say is, why would you want to do that? And that would be number one. And I think that's part of a difference maker for us and them. And Lenny and I were both trained down in Birmingham, Alabama with Dr. James Andrews, and he's one of the people that I've always looked up to with how he handles things like that. He is the most accessible person I've ever worked with. He's answering the phone all day. I mean, if Lenny or I or anybody, if you right now just called his cell phone right now, he'd answer. So it's amazing, and I think that's part of his success, is being accessible. So for us, that's part of our niche, right? Especially since we're a cash-based practice, out of network with insurance benefits. For us, that's part of it. I have people text me at 9 o'clock at night saying, "Hey, I was shoveling earlier today, my back's spasming. Can you squeeze me in the morning?" I mean, if they had to go through like a front desk and all those things that aren't vested in our business and sort of thing, I don't know if that goes well. But I don't know. I hate to use the word concierge, but I feel like we're really here for the clients, and we're here for them, to help all the time. So I would say I recommend it, and I've always been like that. And that's kind of sports medicine, I guess. When I was an athletic trainer more, you're available for the team at all times, essentially, and I feel like I've extended that to my current clients now. So I would say you do that. How do you balance it? I do think you set limits. You say, you're not going to check text messages all day, but like maybe you batch them where it's not very uncommon for me to have 6, 7, 8, 20 unread text messages over the course of the day, and I'll get to them when I can sit down and dedicate some time. But I'm not gonna be looking at dinner. We're all guilty of doing that, I think, sometimes. But for me, it's about being accessible, but trying to chunk your time. So I'd say definitely do it, and I'd say there's a way to do it. I think if you're, hey, I'm only working 9 to 5 and I'm totally unresponsive out of there, I don't know. I get my clientele doesn't want that. So maybe your clientele does, but I don't think that's our clientele.
Yeah, it's a good answer. I would definitely agree with that. Coming from the Birmingham model, going back, we were busy, and I didn't have a vested interest necessarily in the business besides my patients getting better, which is huge. I think you got to prioritize. Are you in it for your clients 100%, and you want that access? They're going to appreciate it. Word gets out to their friends, and believe it or not, it could make your business that much better and set you apart from the group that I potentially may have come from, where I wanted to shut it down, and you could find me Monday if you needed me. And that's not what we do here. And we don't advertise a concierge-like thing, but in our heads, that's how we're running the business.
Yeah,
it's huge, and people definitely appreciate it. I hear it all the time. They're so shocked that they get a text message from me Saturday night or whatever. Try not to do it at dinner like Mike said, but they're pleasantly surprised at how responsive we are.
Yeah, and then, I mean, who do you think they're going to text or whatever when they sprain their ankle in a month too? It's going to be you.
Right.
It's going to be just direct to you because they know they can just text you and you're going to respond and get you in ASAP. So.
And these are established clients. These aren't just random people that are texting us and looking for advice. I'm not going to give somebody medical advice if I don't know the situation. These are established clients that we know their situation, we know their history, we know a lot about them, and we're willing to help them out, quickly, and then get them in probably that week if it is a weekend to figure it out.
Nice disclaimer. That was good. That was like Lenny's legal disclaimer right there.
The lawyers told me to say that.
What do we got, Gabe?
All right, question number 2 comes from Sydney, Australia.
Sydney, Australia. Awesome. Very good.
Harrison Dill writes, what is your assessment protocol for middle and late stage ACL reconstructions, and what is your criteria to return to sport?
All right, so Harrison said, what are our, I like rereading the question for some reason. I guess I'm used to that from seminars, I guess. So how do we assess middle to late? So we'll just call them advanced ACL reconstructions and return to sport. Heck, back in the day, we used to do it all. Back in the day, back in Birmingham in the early 2000s, we used to do obviously a clinical exam. We used to do a KT test, an arthrometer, where we're actually measuring the amount of laxity side to side. We used to do isokinetic testing. We used to do hop tests, that type of thing. So one of our mentors, Kevin Wilk, actually shares a really good story about why he stopped doing hop tests, by the way. I don't know, do you know this story? He said they used to do hop tests a lot just because it was pretty popular. And I know a lot of great therapists that still do. Right. Bob Mangine talks about it all the time. I'm trying to think of who else I know does it all the time. I know all the guys at Cincinnati Sports Medicine do it. Kevin shared a story of somebody he was doing a hop test for that hopped and retore their ACL. And he hasn't done one since. So I don't want to speak for him, but that's very interesting with hop tests. So we used to do it all. Now we don't do any of that. For us, I think the number one assessment I do is, have they had an appropriate rehabilitation progression? And I hate the timelines with protocols where somebody says, well, it's week 12, I can jog. Well, you're supposed to get your motion back, you're supposed to get your baseline strength and dynamic stability, you're supposed to get some strength up, you're supposed to start these activities. You don't just jump to running because it's whatever, week 12, I'm just making up numbers, but it's week 12. You jump to it because you've met the right rehab progression. So I would say my first and foremost is that. Len, your take.
I mean, I agree. It's definitely not a cookbook treatment, so hopefully you've had the person in since post-op day one, or whatever, post-op week 1, and you've seen them mature through the process. And to me, that's huge to how well they hit their milestones in my head. Full motion 4 weeks, at late 6 weeks. Did they get stiff? Were they really swollen when they came in? Did they have any other issues? Did they have meniscal repair versus debridement? Do they have any bone bruises? Probably. If you look at the literature, most people get some kind of bone bruise. To me, that may delay things a little. Is it a patella tendon autograft versus an allograft versus a hamstring? So all that plays into my head, and then it turns into, at 3-4 months, it turns into like just getting strong. To me, the ligament is well healed, and now they're out there, doing everything. They're doing deadlifts, they're doing squats, they're hitting all that, and making sure their quads are coming in, the hammies are coming in, their hips are strong, and then you're progressing them in their functional. Are they running? Are they cutting? How are they responding? How's their knee respond? Are they able to maintain pain-free, any swelling occur, and all that stuff plays in. So it's tough to say, a general term on everybody because everybody responds differently.
Yeah, and what are you going to do if it's 6 months out and they're trying to return to sport and you feel like their anterior drawer, their Lockman is a little more loose on that side? What do you do?
More often than not, their quads are tiny, which we have this thing in our head where 6 months they should be ready to go. That's certainly not the case. I've seen 6 months, quads are tiny, and the doc's like, yeah, 6 months, you're ready to go. Let's go play soccer or football. And how many of those come back with a re-injury, or how many of those 5-10 years later develop arthritis or some kind of meniscal injury, and you're thinking, crap, did we get them back too quickly at that 6 month? Maybe we should have waited 8 months or a year, which to me is more ideal.
Yeah, I mean, when it comes down to it, it comes down to, are they physically ready? So have they gone through the progressions and have you witnessed them do them well? So when it comes to strength, I think the research and the studies have shown that you're even weak 12 months after an ACL reconstruction. So it's not necessarily that. You're going to return before 12 months. You're not going to surprise me. I don't need an isokinetic test because I've been watching you through the process. You're out in the gym, you're squatting, you're deadlifting, like Lenny said, you're doing these types of exercises. I know that you're loading that limb. So I don't need to do an isokinetic test anymore, but I need to see you do the right activities. I need to see you running and doing agility work, those types of things. So if you're a physical therapist and you don't have access to some of this stuff at your setting, you got to get a good relationship with the Sports Performance Center, in my mind, and really work with those coaches and the personal trainers there to do that. So something to keep in mind as well. So I think the older we get, I think we have less of a definitive checklist. You have to meet this, you have to meet that. You have to present well, and I guess that comes with experience too of what you should look like.
Yeah, so. Definitely.
All right, Gabe, number 3, what do we got?
Last question. Tom from Connecticut asks, have you ever had a case that completely stumped you?
Len?
No.
I never have, Len.
I nail it at the first time. I'm like an Olympic gymnast. Stick the landing. Of course not. No, every day is a challenge. Every day, you never know what's going to come through your door. You never know, what is going to present one way, and somebody's going to have some crazy symptoms or not tell you the whole story. We just had somebody recently where you're slowly getting the information out of them, and you're like, oh, why didn't you put that in your history? Oh, I didn't think it mattered. Well, you see, that's key for a therapist is to know what questions to ask, because the patient, again, I'm going to hit this almost every time I speak at this podcast, is the patient has the information. You just need to know how to pull it out of them. And that helps a ton in your assessment. And again, of course, we get stumped all the time, and that's why him and I are bouncing stuff off each other, and that's why I recommend, especially young therapists, get in a clinic where there are a lot of PTs where you can, when you get stumped, not if you get stumped, when you get stumped, you can talk to them, because you're going to need that. Right.
And I would just say, I don't, maybe we don't get stumped every day, but we get stumped a lot. I have a thing I call my scratch your head test, and this comes up a lot. And anytime you go through your assessment, your clinical examination, whatever it may be, and you think you know what you're doing, and the person doesn't respond the way you expect. When that happens, I call it a scratch your head moment, and I'm like, okay, that's interesting. I was expecting it to go this way, and it didn't. And the first thing I think of is I'm missing something. And in the past, I've found cancer. We just recently found somebody with a tumor in his back that, why isn't he responding? Why does he have back pain? He's not responding to the care we're giving him. As an athlete, that's kind of weird, right? So again, we're like, all right, let's get a full workup. Let's send him for some specialists there. And he had a non-cancerous tumor in his back. It's one of those things you scratch your head a little bit, but we found cancers, we found just really goofy things that don't add up.
Goofy things like shoulder pain that's been diagnosed as tendonitis or bursitis or biceps tendonitis, whatever, and you gotta start thinking out of the box. Is it thoracic outlet? We've been seeing a lot of stupid stuff, not to go into specific diagnoses, but when things don't add up, definitely, yeah.
Yeah, so everybody gets stumped all the time, so don't worry about that. Just realize that when you're stumped, it's probably time to say, what are we missing? Right. And I think that's the point. Do a reassessment, and oftentimes it's just not normal. People don't look like the anatomy textbook that Netter and even Da Vinci drew. So people just aren't like that. You have to realize that that's just not the norm. So there's a lot of anomalies out there. So. Awesome. Well, thanks so much, guys. Another episode in the books. I hope you're enjoying it. I hope you like the length of these. We're trying to keep these kind of brief and condensed in doing these there. But your feedback is welcome. Hit us up on social media, or post something on the website. Give us some feedback on what you like, what you don't like. But more important, we need your questions, because this is really how we want to do the podcast. Is we want to answer your questions instead of just force feeding you what we want to talk about. So ask us questions. MikeReinold.com/podcast. You can find some information, as well as using the hashtag AskMikeReinold on Twitter if that's how you want to do it. So do all those. Help us out. Subscribe on whatever you use to listen to podcasts, and we'll see you on the next show. Thanks so much.
Thanks, guys.